Welcome everyone. Myself Dr. Yash Hirani from Physiology Department, MP Shah Medical College, Jamnagar. Today's our topic of discussion is visual acuity and color vision. So let's learn about this. So first we will learn about visual acuity. So what is visual acuity? It is defined as minimum separable distance between two stimuli at which they are just resolvable. So it can be perceived as two separate stimuli. So what its importance is, it helps us in determining outline, form or shape and other minute details of the object. So visual acuity is the reciprocal visual angle, means it is the degree to which the details and contours of the objects are perceived. So what is visual angle? It is an angle subtended at the nodal point of the eye, and it is expressed in terms of resolving power of the eye. So what is nodal point? It is the center point of a lens. Like we take an example over here given below. There is eye on the left side and there is a flower on the right hand side. So from the upper hand and the lower hand, two rays are coming from the flower and those two rays are meeting at the center point of lens. That is the nodal point, and the angle between those two rays formed is known as visual angle. So it is angle subtended by an object on the nodal point of the eye. What are the factors affecting visual acuity? There are three types of factors. One is stimulus factors coming from the stimulus. Second is optical factors. Third are the retinal factors. Okay, so what are the different types of stimulus factor? It can be size of the object, color of the object, brightness, contrast, illumination of the surface. Now what are the optical factors? Those are error of refraction, curvature of cornea and lens, plasticity of lens, condition of ciliary muscles and lens ligament. Now what are the retinal factors? Those are site of the retina where image is formed. This is an image demonstrating visual acuity for 2-point source of light. So when there are two objects at a distance of 1 millimeter from each other and at a distance of 10 meters from the eye, when their image is formed on the retina, the distance between those two images will be 2 micrometers. Now this is the minimum distance at which your eye can identify those two objects as two different objects. If distance between those two images formed on the retina is less than 2 micrometer, then our eye will see that object as one only. So for an object to be seen clearly, it must subtend a visual angle of at least 1 minute at the nodal point of the eye, like mentioned here in the diagram. Now moving on to errors of refraction. So what are the errors of refraction? One is myopia, another is hypermetropia, and third one is astigmatism. Myopia is also known as nearsightedness and hypermetropia is also known as farsightedness. So what is myopia? It is a type of refractive error in which parallel rays of light coming from the infinity are focused in front of the retina instead on the retina when accommodation is at rest. So this causes distant objects to be blurred while close object appears normal. Like as here seen in this image, rays coming from the far are focused in front of the retina instead of on the retina. So vision becomes blurry. So what are the etiological factors which results in myopic vision? It can be three factors. It can be either axial myopia, means there is something related to the axis. Curvature myopia, something related to the curvature. Index myopia, something related to the index of a particular refractive object. In axial myopia, it results from the increase in the anterior-posterior length of the eyeball. So the length increases. In curvatural myopia, it occurs due to increased curvature of either cornea, lens or both. So curvature is increased. In index myopia, it results from increase in the refractive index of crystalline lens associated with the nuclear sclerosis. So the lens which we have in eye gets sclerosed and so its refractive index increases, and that's why it results in index myopia. So here is an image showing myopic vision. First image is a normal side. So the rays coming from infinity are being focused on retina exactly. But in the second image, rays coming from infinity are focused in front of retina. So if we need to correct this type of a disorder or this type of refractive error, what we can do is we can put something in front of the eye so that rays get a little bit diverged. and so they converge a little bit farther away than that they are currently converging it. So the image will be formed at retina. So management is either medical or surgical. In management, we can put concave lenses in the form of glass or contact lenses, right? So image will be formed on retina. In surgical, we have radial keratotomy, LASIK laser, and either removal of crystalline lens also. Now moving on to hypermetropia, means farsightedness. A person is able to see objects which are at far clearly, but near objects are seen blurry. So it is a refractive state of eye wherein parallel rays of light coming from infinity are focused behind the retina, with accommodation being at rest. So in myopia, rays were being focused in front of retina. In hypermetropia, rays are being focused after retina. Okay. So what are the etiological factors? Same as in myopic, we have axial hypermetropia, curvaitural hypermetropia, and index hypermetropia. And there is also something which is also another factor known as aphakia. So what are these? In axial hypermetropia, it is by far the commonest form. Why? Because it occurs due to short axial length of the eyeball. Axial length of eyeball shortens. In curvature hypermetropia, it occurs due to comparatively flatter curvature of the cornea or lens or both. In index hypermetropia, it results due to change in the refractive index of the lens, so it becomes less. So whatever was happening in the myopic vision, it is exactly happening opposite in this hypermetropic vision. And there is another thing called as aphakia. What is aphakia? Means there is absence of lens. So if there is no lens, the rays coming from infinity won't get converged. So they'll be converged a little bit later. So the image is formed after retina. So here is an image depicting hypermetropia. First image, normal sight image formed on retina. Second image is hyperopia or hypermetropia, image formed after retina, because eyeball is too short. So in order to get those rays being converged a bit earlier, so that image can form on retina, we use a specific kind of lens for this. What kind of lens we use? We use convex lens, so that rays coming from farther gets focused on retina. That is a medical management. And in surgical management, we have refractive corneal surgery for hypermetropia. Now moving on to another refractive error, which we call it as astigmatism. Astigmatism is a refractive error of the eye that causes visual image in one plane to focus at a different distance from that of the different plane. So in one plane, image will be formed at some another distance than that of the other plane, which we call it as astigmatism. So there are different types of astigmatism. One is regular, another is irregular. In regular, we have horizontal-vertical, oblique, bi-oblique. In horizontal-vertical, we have with the rule astigmatism and against the rule astigmatism. So for the treatment part, in regular astigmatism, we can either correct it medically by giving some optical correction or surgically. In optical correction, we give spectacles like concave convex cylinder lens, contact lenses like toric lens, prismblastic lens, and in surgical we use keratomylusis and excimer laser. Now, in the treatment of irregular astigmatism, we give hard or semi-soft contact lenses, or we can also do keratoplasty in central area of conical cornea, or we can also do excision of scar if there is one and replace it by a graft. Now moving on to another thing which a lot of students get confused in, that is presbyopia. And one thing you need to remember from this is presbyopia is not an error of refraction, but it is a condition of physiological insufficiency of accommodation which leads to failing of near vision. It is usually occurring after 40 years of age. Okay? It happens due to decrease in accommodation power of the crystalline lens with increasing age. That leads to presbyopia, and it occurs due to decrease in elasticity and plasticity of the crystalline lens. There is age-related decrease in the power of ciliary muscles as well, which also contributes in this. There are some causes of premature presbyopia. Those are hypermetropia, primary open-angle glaucoma, premature sclerosis of the lens, and excessive close work. Moving on to physiological differences between glasses and contact lenses. In position relative to eye, glasses are a little bit further away as compared to that of the contact lenses, because contact lenses sit directly on the cornea, In image size and perception, glasses can slightly magnify or minimize the image size, but contact lenses provide more natural image perception. Oxygen supply to cornea is hampered in contact lenses, but in glasses there is no impact on oxygen flow. There is an effect known as jack in the box effect, which is present in glasses but it is absent in contact lenses. So what is it? When you wear glasses, there is certain amount of your visual field around the glasses on the peripheries which is not covered by your glasses. So in that visual field you see blurry vision because that visual field is not being corrected using glasses. So that is known as jack in the box effect. While the visual field which is covered by your glasses, you will see corrected vision, you will see clearly. While in contact lenses, your whole of the visual field is covered by contact lenses because contact lenses sit directly on the entire cornea. So there is no jack in the box effect. Now light aberration. It is present in glasses while it is absent in contact lenses. So what is light aberration? Glasses sit a bit further away from the cornea. So when light rays come from any object, it has to pass through the glasses, then through again air medium and then towards the cornea. But in contact lenses, rays come directly from the contact lenses towards the cornea. There is no medium in between. So in glasses, there is a medium present between glasses and cornea. So light might get aberrated in that refractive medium, which is air. Now eye adaptation. Glasses require minimal adjustment and those are easy to wear, while contact lenses may require adaptation and require expertise to wear contact lenses. And there is also risk of irritation and infection in contact lenses. Now we have learned about vision and different types of refractive errors of the vision. Now let's learn about how to check whether a person is having correct vision, normal vision or not. So for that we have different tests for distant vision and for near vision. For distant vision we have this type of test or this type of charts that we use. One is Snellen's chart, Landolt ring chart, E-test chart, finger counting method, hand movement and perception of light. So moving on to Snellen test. So what is the principle behind this? In this there will be a chart which I'll show you in next slide. In that each individual letter subtends an angle of 5 minutes and each component of a letter subtends an angle of 1 minute at the nodal point of eye from the distance in meter, which is written as numerical on the chart. Now it has different number of letters in different rows and letters in top line should be read clearly at a distance of 60 meters. Okay, and subsequent letters should be read at respectively 36 meter, 24 meter, 18 meter, 12 meter, 9 meter, 6 meter and 5 meters respectively. Okay, so let's learn about this in a bit detail. So this is a Snellen's chart. So what is the procedure of identifying the vision of a particular person using this chart for distant vision? Subject will be asked to stand at a distance of 6 meter from this chart and this chart will be placed at an eye level of that particular subject. So there are different letters written on this chart of different sizes. First line is having a bigger letter below which it is written as 60 and in second line it is written as 36, third line 24 and likewise. So what is the functionality of writing 60 below that first line? If there is a normal person who is standing at a 60 meter distance, he will be able to read that particular first line letter from that 60 meter distance. Then his vision will be normal. Okay? But here we are making subject to stand at a distance of 6 meter. Now we will ask him to close one of his eye. Respectively, we will check vision of both the eyes. So now we will ask him to start speaking the letters from top till the bottom line, whichever line till he can read. If he is able to read only first line, then his vision will be 6 by 60. Means a normal person is able to read that particular letter from 60 meters, but he is able to read that letter from 6 meters. Now he is able to read till second line, his vision will be 6 by 36. If he is able to read till third line, his vision will be 6 by 24 and likewise. If he is able to read till the last second line, then his vision will be 6 by 6 and that is a normal vision. Okay. But what to do if that person is unable to read the first line only from that 6 meter distance? We will ask him to come nearer to the chart by 1 meter. And now we will tell him to read the first line. If he is able to read the first line from that distance, then his vision will be 5 by 60, because he was able to read that first line from 5 meters. Now if he is unable to read that letter from 5 meters, then we will ask him to come up 1 meter nearer till he can read that first line. If he is unable, likewise we did, and if he is unable to read even from the 1 meter distance, he is unable to read first line from the 1 meter distance also, then what we will do? We will do some different procedures afterwards, like perception of light, hand movement, and finger counting method, which we will learn further on. Okay? So what is the basis behind this test? In this, two distant points are visible as separate only when they subtend an angle of 1 minute at the nodal point of the eye. So this is a Snellen chart like I showed you in previous slide. Now this is Landolt test. It is similar to Snellen's test, but instead of letters here are broken rings, and we need to ask patient in which direction that broken ring is particularly directing towards. Okay, so each broken ring subtends an angle of 5 minutes at the nodal point, like for the Snellen's chart. So people who are illiterate or who does not know how to read can identify using this type of charts. On the left hand side there is Landol's ring chart in which there are broken rings, and on the right hand side we have E chart. So a patient need to identify in which direction that particular E is opening. So these are different type of Snellen's chart, Landol's ring chart, E chart, in different languages, in different circles, okay, for different type of people. So this is a video demonstrating how to check for distant vision using Snellen's chart, and person is standing at a distance of 6 meters from the chart. Now in this video, if a person is not able to read that first line from that particular distance, we will tell him to come 1 meter nearer to the chart, and if still not, then still 1 meter nearer. Okay. Now we will learn about finger counting method, hand movement, and perception of light. In the respective slides, I'll show you some video. First will be finger counting method, then will be hand movement, and then perception of light. So if person is not able to read from 1 meter distance the first line of Snellen's chart, then we move on to this method. Now we show him fingers and tell him to identify the count of the fingers, and if still not, then we tell him to identify if you can see that I'm moving hand or not. That is known as hand movement. And if still he cannot perceive that hand movement, we tell him, we show light directly in his eye using torch, clinical torch. So if he is able to perceive that light or not, he has to tell. And if still not, then we refer him to the ophthalmology department. Okay. This examination is being performed from a distance of 3 feet. So till now we have learned about distant vision and test for distant vision. Now we'll learn about how to check for near vision. So to check for near vision, we have tests like Snellen near vision chart. We use it to check for near vision. Jaeger's chart, Roman test chart. So what are these things? We learn right in the next slide. So in Jaeger's chart there will be prints, written lines which will be marked from 1 to 7. So depending on whether that person is able to read that particular line, we give him vision as J1 or J7. In a Roman test type, we have Times Roman font with standard spacing, and likewise there will be vision N5, N6, N8 till N48. In Snellen's near vision test type, there will be graded thickness of letters in 1 to the 17th of the distant vision chart letters by photographic reduction. So letters will be equivalent to 6 by 6 line, which will be subtending minimum 5 minutes at average reading distance, that will be 35 centimeter or 14 inches from which we read normally. Okay, so this is how a Jaggers chart will look like. Person has to start reading from the bigger size letter till the smaller size which he can read, and likewise will be the vision. If he can read only the number 11 paragraph of this chart, will give him vision as J11. If he is able to read till number 7, we give him vision as J7. Okay, this is a video demonstrating how to check for near vision using Jaggers chart.
પછી ફિલ્ડ વિથ થનોર્થમ સેન એબલ ટ્રી.
So this is near vision Snellen test type chart. So first letter E. If a person is only able to read this letter, we give him his vision as 20 by 200. That means that letter must be read at a 200 centimeter distance for a normal person, but you are only able to read that from 20 centimeters. So your vision is 20 by 200. But for a normal person, he will be able to read till line 8. Means the letter which must be seen from a 20 centimeter distance, he is seeing at a 20 centimeter distance. Okay. Now moving on to color vision. So what is color vision? What is color? We have primary colors and we have complementary colors. For primary colors, we have red, green and blue, which are primary colors. And complementary colors are when these two colors are mixed in appropriate amounts, it leads to the cancellation of the color sensation, producing the sensation of white. Means when you mix these two colors, you get a formation of another color. So those colors which are formed by mixing of primary colors are known as complementary colors. We have trichromatic theory of color vision, which was proposed by Young and von Helmholtz. So according to them, there are three types of cones in the human eye: red cones, green cones and blue cones. Red cones are known as erythrolab, green cones are known as chlorolab and blue cones are known as cyanolabs. So how we see colors? All visible colors are formed by mixing different levels of red, green and blue light. The brain processes the signals from these cones to create the perception of various colors. So basically there are three colors only: red, green and blue, but by mixing different amounts of those colors, we get another color and we see that another color. Okay, but those are basically just these primary colors only. This is a visible spectrum of light showing different wavelengths for blue color, green color and red color. So for blue peak wavelength is 445 nanometer, for green it is 535 nanometer and for red color it is 570 nanometer. Means at those wavelength that color is seen in peak quantity. Now moving on to color blindness. What is color blindness? When a single group of color respective cones is missing from the eye, the person is unable to distinguish some color from the other. Now there are different types. If a person lacks red cones, he is known as protanope. If he lacks green cones, he is known as deuteranope. If he lacks blue cones, he is known as tritanopes. Depending on the cone he is lacking, he won't be able to see that particular color. Okay. Now, if he is not missing that particular cone completely, but he is having some reduced sensitivity to that particular color, like for red, that person will be known as protanomaly. For that green, he is known as deuteranomaly, and for blue color, he will be known as tritanomaly. So this is some kind of color blindness present in that particular person. Either he is completely missing that type of red particular cones, or he is having reduced sensitivity to that particular color. Depending on that, we define these terms. Okay. Color blindness is a genetic disorder. Like for red and green color blindness, it is almost exclusive for males. Why? Because its gene is located on 23rd X chromosome and males only have one X chromosome. So if that particular X chromosome will be defective, then male will be completely blind for that particular color. Okay. But female almost never have this blindness, because one of her X chromosome will always have normal gene, because female have two X chromosomes. So if one is defective, another might still be normal, so she will be able to see that color clearly. Because of this, female will mostly be color blindness carrier. Like out of all women, 8% of women are color blindness carrier. Okay. This was for red green color, but for blue color, its blindness is very rare. because its gene is present on 7th chromosome, and 7th chromosome have 2 pairs of chromosome. So if one chromosome is defective, another might be normal, so you won't be able to differentiate that blindness that precisely. Okay, so that color blindness is very rare. So abnormalities of color vision, we have total color blindness, mild color vision defects, or partial color blindness. For total color blindness, we call it as monochromacy. For mild color vision defects, we call it as trichromacy. If there is reduced sensitivity to red, protonormally, reduced sensitivity to green, deuteronormally, like we have discussed earlier. For partial color blindness, dichromacy. That also we have discussed earlier. For red color blindness, protanopia, green color blindness, deuteranopia, and blue color blindness, tritanopia. Okay? These are the tests for color vision. First one is Ishihara chart, second is home grain wool matching test, third is Eldridge green lantern test. First we will learn about Ishihara chart. So what is Ishihara chart? In Ishihara chart there will be spots. These spots are such that they are liable to confuse with the spots in the background by people with defective color vision. These plates are so constructed that a person with color vision defect will read a different number from a normal person. So there will be numbers on that particular chart formed by using spots, different colors of spots. So if a person is having a normal vision, he will be able to identify that particular number hidden in those spots. But if there is defect of some kind in any of the kind of cones, red, green or blue, that person will be reading some another number then which is already present. Okay, so by this we can identify that person is suffering from some type of color vision. This is an example of Ishihara chart. Like on the left hand side there is 74 written, and on right hand side there is 42 number written on that chart. For a normal person, he will be able to identify these numbers easily. This video shows the demonstration of using Ishihara chart for color vision.
29, 57, 5, 3, 15.
Now these are two particular Ishihara charts. Like on the left hand side there is 8 written, and on the right hand side 57 is written. But if there is a person with red green color deficiency, he will read first image as 3 and second image as 35 instead of 8 and 57 respectively. So by this we can identify that particular person is having some type of red green color blindness. So this is a table of keys that you will be having in your labs for particular Ishihara plates. Like from number 1 to 10 there are different numbers which will be written on that plate, and for normal person he will be able to identify that normal number. But for red green color deficiency person, he will be able to identify that number as another different, like first number is 12, so he will be able to identify that as a 12 only. But in second it is 8, he will identify it as 3. And total color blindness person won't be able to identify that there is any number or not. He won't be able to see any number in it. And in third number there is 6. Red green person deficiency, red green color deficiency person will read that number as 5, but total color blindness will read it as nothing, and likewise. So these are kind of a particular keys that you have in your labs. Okay, so next is home grain wool matching test. What we have to do in this test, the person has to just basically match the kind of wool that examiner is holding. So different color wools will be placed together, and the subject will be given a colored wool and will be asked to pick a similar colored wool from the bunch of wool that he is holding. Okay? હું તમને જે કલરનું wool દેખાડું ને એવું તમારે આમાંથી તમારે મેચ કરવાનું છે, બરાબર? Another test is Eldridge green lantern test. This is Eldridge green lantern. It consists of different colored windows with light source in the center. Subject should identify the color of that particular window. Effect of mist or fog on the colored window can also be studied using this test. This is used for testing railway employees. This test is important in pilots, navigators, vehicle driver, railway employees to identify different colors from a certain length, certain distance. There are other tests also to measure for eye, like electroretinography, which records the electrical activity of retina, visual evoked response, fundoscopy, in which we are able to see fundus of the eye directly. So this is the end of our topic. I hope you must have learned something from this video. If you have any doubts, you can comment down below and I'll try to answer them as quickly as possible. Thank you.